G'day. Welcome to Emergency Medicine Topics in one coffee. I'm Giles, I'm an emergency physician, and today we're going to talk about ectopic pregnancy. I'd like to first just to tell you about an illustrative case of a lady that presented to an emergency department that I work at. So this lady is 35 years old, and she's presented in the early morning with 1.5 hours of relatively rapid onset lower abdominal pain. She denies that she's pregnant, and she's seen at triage and given a category 3. Now you can see that her blood pressure is down a bit and she's a bit tachycardic. Unsurprisingly, as a category 3, she's seen by a relatively junior doctor who, as part of the differential diagnosis, did consider an ectopic pregnancy, but given that she said she wasn't pregnant, actually thought that a urinary tract infection was more likely. They took blood for full blood count, UEC, etc., were waiting for a urine to come back, and they added on a beta-HCG to the bloods that had already been taken. They didn't have a great urgency for a pelvic ultrasound, and radiology was busy, so it would be about 2 hours' time. Unfortunately, what happened in that ensuing 2 hours is that she became more tachycardic, she developed increased abdominal pain. Fortunately, she was seen and reviewed by a more senior emergency doctor who did a bedside ultrasound which was grossly positive for free fluid. The beta-HCG was in fact positive, and that combination of the positive fast, the beta-HCG positive, she was rushed to the operating theatre, where in fact she had about 1.5 litres of hemoperineum. Now she survived this ordeal, although she did lose the fallopian tube on one side. So what we might do is go back and have a look at a little bit about ectopic pregnancy so we can decrease the chance of this sort of presentation occurring again in either your or my emergency department. The vast majority of ectopic pregnancies implant in the fallopian tubes near the ampullary end. There are a smaller percentage that are found in the cervix, the ovary, even intra-abdominal. Now, you'll see online in books lists of risk factors for women to get ectopic pregnancies. The ones which I would remember really are red flags are those patients who have had ectopic pregnancies before and patients also who are on IVF. But remember that 50% of patients who get ectopic pregnancy have no identifiable risk factors. So it's really important that for any patient that presents of childbearing age, even if they deny they're pregnant, assume that they may be, especially if they present with syncope, abdominal discomfort, amenorrhea, scanty PV bleeding. All those things should make you think, does this patient have an ectopic pregnancy? Now, what will you find on physical examination? Well, it depends on whether the ectopic pregnancy is ruptured or not ruptured. If it's not ruptured and it's in the fallopian tube, you might get some lower abdominal pain, sort of pelvic on one side, but not a lot else. And so under those circumstances, there may be other differentials like appendicitis. In patients who have a ruptured ectopic pregnancy, you'll get moderate to severe pain. And depending on the degree of hemoperineum, you'll get peritonism. And you may even get irritation of the diaphragm and get some shoulder tip pain. You need a fair bit of blood for that to occur. Now, with these sort of patients that come in, they're cardiovascularly, they're young. They can usually compensate pretty well. They might get a tachycardic, but remember they're in pain also. Their systolic blood pressure won't drop until quite late, and when it does, that's when they'll crash. So what we might do now is, let's have a look at a couple of different clinical scenarios and what investigation and treatments are available. All patients presenting to the emergency department who you think may be pregnant need to have an intravenous line-in, they need to have a full blood count, they need to get an urgent beta-HCG blood or urine. That's a starting point. If you suspect that they may have an ectopic pregnancy, they require that urgent beta-HCG and they require bedside ultrasound. Now, almost every emergency department, and certainly every one, should be able to do a fast ultrasound. If the patient is beta-HCG positive and they are fast positive, so they've got free fluid in the abdomen, they need to get liaised with O&G and go to the operating theatre emergently. If, however, you do a bedside ultrasound and it's negative and they're beta-HCG positive, then they should get an urgent pelvic ultrasound done by the specialist ultrasonographer at radiology. Because I think that this skill of seeing that there's an ectopic pregnancy in the fallopian tube and an empty uterus, for most emergency departments, they don't reliably have that skill. Now, what will happen to these patients? Well, we've talked about, of course, the ruptured ectopic pregnancies. They go to laparoscopy and they try and save the fallopian tube. What about for the ectopic pregnancy that's in the tube, but they're not cardiovascularly compromised, it's not ruptured? Well, there's either the surgical option, which is going to the operating theatre and trying to save the tube. There's also occasionally used a medical option, which is the use of methotrexate. So in selected patients, the O&G team may decide to use methotrexate. So when I say selected patients, they need to be closely kept an eye on by the team. In patients that have an ectopic pregnancy of less than 3.5 centimetres, then methotrexate, well, it's a chemotherapeutic agent, isn't it? So it targets rapidly dividing cells, like a fertilized egg, and it terminates the embryo, and then the patient either resorbs it back into their body, or they abort it, or it is passed in the next period. But remember, this is for quite specific subgroups of patients. There's a few other things that we probably should just mention. Your beta-HCG normally during pregnancy in the first trimester, it doubles every about 48 hours. It decreases through the second and third trimester. Another question that comes up is, what's the chance of a heterotropic pregnancy? That is, where you have a pregnancy in the uterus plus you have an ectopic at the same time. It's thought to be about 1 to 4 to 1 to 8,000 in the general population. However, in patients on IVF, it increases to 1 in 100 to 1 in 500. So it's not that uncommon. Okay. Well, I think we've got time for a couple of take-home messages. I'd really like to drill down on, if you think a patient presents in childbearing age, and even if they say they're not pregnant, assume that they are, or you will get burned. If they have symptoms related to syncope, PV bleeding, amenorrhea, abdominal pain, anything that just doesn't quite make sense, make sure you assume they're pregnant and you do a beta-HCG. On all patients that have potentially ruptured ectopic pregnancy, or you really think they could have ectopic pregnancy, make sure you do a bedside ultrasound and an urgent beta-HCG, because that'll help direct your management. And finally, make sure you liaise with the O&G team early, so they don't get a call hours later, the patient's been in the emergency department, so that we can direct their care appropriately. Okay, I think they'll just about do for ectopic pregnancies in one coffee. I'll see you next time. Cheers.